invitation to speak. See if we can get this up now. It should work. So in 20 minutes, I'll try and go through diet and exercise. Usually, it'll come up usually, just a sec. Should be there now. Usually it's a half an hour talk for each of these topics, so I'll talk rather quickly so I can try and get through this. And again, thank you very much to the organizers. It's great to be here. Lovely to be at a patient meeting to integrate all of this work and to be here with some of my esteemed colleagues. From a disclosure perspective, first of all, Sanofi Enzyme, we're involved in a current clinical trial, and I've received speaker honorarium from them before. And I'll talk a little bit about some of our work with a company called Exerkine, and I'm the founder and CEO of that company in full disclosure. So the first thing I'll briefly mention is a study that we did several years ago looking at patients with muscular dystrophy, and we were looking at their nutritional inadequacy. And although we didn't have Pompe patients in this study, the results are very applicable, and we've recently got similar data in our Pompe patients. And what we did is we did prospective dietary analyses in a number of patients with Duchenne, myotonic dystrophy, FSH, and limb-girdle, and we repeated it twice. So we did it over a 5-month period, so we did it twice for reproducibility, and we compared their dietary intake to the Canadian recommended daily intake. And what we found is it doesn't really matter what disease, mitochondrial disease patients, myotonic dystrophy type 1, or limb-girdle dystrophy, we found that many of the patients were consuming suboptimal energy. And that might seem a little bit strange, but if you think about it, patients aren't moving very much, and so as a consequence, to avoid obesity, you really can't take in as many calories. The problem there is that your repertoire of vitamins, minerals, protein, etc., then are reduced because your total caloric intake is down. So what we found is that even the Canadian recommended daily intake for protein, which is quite a bit lower than what we'd recommend for patients with muscle disease, about 10 to 15% of patients were not meeting that. Many patients were on a very high-fat diet, and that's going to be relevant in a minute when I talk about obesity, which might be contributing. But if you start to look at some of the micronutrients and some of the vitamins and minerals, a fairly large proportion of patients were deficient, at least from a dietary intake perspective, in taking in many of the vitamins that are important for nerve health and also for muscle health. And what might the consequences of that be? One would predict that if you're not taking in as much, that your blood levels would be low and many patients would be deficient. So don't laugh at the date from this. I haven't waited 25 years to publish this, but we had an old database that we could actually extract data from, and our new one doesn't work. So we had a postdoc who was with me extract this data from almost 2,000 patients in our neuromuscular disease clinic. And what we were looking at were a variety of different vitamins that we could measure in the clinic and seeing what proportion of patients were deficient in these important vitamins. And what we found is important vitamins like red blood cell folate, which if deficient can cause neuropathy, vitamin B12, the deficiency of which is the most common cause of neuropathy next to diabetes in North America, vitamin A, which is involved in a variety of different processes, especially retina, and vitamin D, which I'm going to focus on in just a minute. These are the old guidelines, and back when we did this study, deficiency was defined as that which can lead to rickets, which is less than 30 nanomoles per liter, which is very low. However, more recently, it's been quite apparent, based on a number of studies, that in Canada at least, our recommendations are that you should have greater than 80 nanomoles per liter. With these new guidelines, 85% of our patients were deficient with mitochondrial disease neuropathy, but I specifically pulled out our Pompe patients for purpose of this, and 13 patients where we had blood levels before we started to supplement them. 100% were not meeting the current Canadian guidelines, and interestingly, 50% were in the rickets range. So a very, very substantial number of patients had very low vitamin D. And you might say, well, okay, that's bone health, but what does that have to do with muscle? We've actually had several patients over the years who were referred to me for high CK and muscle weakness, and the only thing they had was extremely low vitamin D. So if you have very low vitamin D at very low rickettic levels, it actually causes myopathy. So it's like putting gasoline on a fire that's already burning if you've got Pompe disease or other neuromuscular disease. So next I'm going to turn my attention to obesity, because we've certainly noticed quite a change in the last 15 to 20 years in our clinic and our patients, and we can see that reflected in the general population. So this is a map of the United States showing the proportion of those who are obese as a function of the state. And essentially, the blue and white means that there's a low proportion who are obese. And you can see quite clearly that by 2014, upwards of 30% in some cases of states have patients who are clinically obese. And that's defined as a body mass index greater than 30 or a percent body fat more than 30. But does this have any reflection, or is it reflected, I should say, in our patients? Well, from a publication perspective, there's not a lot of work on this in Pompe disease. And this comes out of a Greek group where they looked at 9 adults where they had what's called a DEXA scan. We heard earlier about a DEXA scan. A DEXA scan doesn't just tell you about bone mineral density, it also gives you body composition. So you get an image like this. This is for the bone, this is for the soft tissue. And then you can tell the proportion of fat and lean muscle mass. This is also perhaps a good outcome for various intervention trials to see if muscle mass is going up. And what they found is 9 out of 9 of their patients had a fat mass greater than 30. So they were in the clinically obese range. But BMI, which is really a ratio of your height and your weight taken together, was underrepresenting the true problem. And the issue here is what we call sarcopenic obesity in older adults, where the muscle mass is small and the body fat is high, but because of the low muscle mass, it hides the extent of obesity. And some people are referring to it as skinny fat. And we're doing a large study now in all of our patients, and we're finding quite a high proportion. So I pulled out our preliminary data on Pompe patients in our hands. 12 out of 13 had a body fat, greater than 30%. So that's almost 100%, but only 25% of these were obese by body mass index. So again, this sarcopenic obesity, quote, skinny fat. Now, very briefly, in full disclosure, going to show you some of our data from our company because we stumbled onto this recently, and that is a treatment for obesity. So it's been well known for many years that there is mitochondrial dysfunction in obesity, and that's my main area of research. So we wanted to see whether improving mitochondrial function would actually help with obesity. So we used the high-fat fed model of obesity. So you feed these guys a diet that's about 80% fat, and you do that for 2 months, and they become obese compared to a chow-fed animal, and that's what they look like. So then after making them obese, we gave them intervention. And we're very interested in the effects of exercise, as you'll see in just a minute. So we wanted to be sure that our supplements weren't negating the benefits of exercise, because there's a strong body of literature that if you take antioxidants, for example, you can actually blunt the signaling which leads to exercise adaptation. So we wanted to make sure that that didn't happen because we're strong advocates of exercise. So 2 of the groups exercised 3 times a week on the treadmill at 15 meters per minute. So the first group that we wanted to look at was what we called a weight loss supplement. So we had our postdocs go and try and review the literature to find the top 5 safe, and GRAS in the US stands for generally regarded as safe components. So it was green tea, black tea extract, green coffee, forskolin, which is an extract from mint, which activates various biochemical pathways that lead to mitochondrial biogenesis, and conjugated linoleic acid, which comes from milk. And then I used my mitochondrial enhancer, which we've shown in patients in a randomized double-blind trial in 2017, which was alpha-lipoic acid, coenzyme Q10, vitamin E, and creatine. And then we added beetroot, because a nice paper in Cell Metabolism has shown that the nitrates in beetroot can actually increase mitochondrial efficiency. So we added that to our previous mitochondrial enhancer. What we had hoped is that the mitochondrial enhancer would have a profound effect on obesity, but reality slapped us in the face. So these are the mice that were all fed a high-fat diet, so you can see that they're much heavier than the chow-fed mice. If you keep giving them fat over 30 days, they get more obese. This is our mitochondrial enhancer, so it was marginally effective, but not as much as we had hoped. We then gave them the weight loss compound, like many other studies have shown. Of course, this has been shown in animals and humans before to work, and it was effective. Fortunately, we mixed the 2 of them together and we created our new metabolic enhancer, we call it, which is a combination of both, and that was this line here, which is very comparable to exercise. So you can see that these 2 are somewhat similar in terms of the efficacy. Of course, nothing's going to be quite as good as exercise. But the most exciting thing is my a priori hypothesis was proven incorrect. And that was when we mixed exercise with the supplements, we didn't negate the benefits of exercise, we actually doubled them. And we brought them right back to a chow-fed animal. We were fortunate to have MRI scans, so you can see this is the intra-abdominal body fat was higher. This is the high-fat control. This is the weight loss, the mitochondrial enhancer. This is the combination, equivalent to exercise, but of course exercise and the supplement brought them back almost to chow. So you might say, well, that's all hand-waving, Mark. One, can you reproduce it independently? And two, what's the mechanism? So we sent these samples to a colleague of mine, Rick Austin, who reran the study. We just blindly gave him the stuff. These are what the fat pads look like. I won't get into it, but these are different fat pads in a wild-type mouse. This is the high-fat diet, and this is what the fat pads look like on the metabolic enhancer. So it was independently validated by a different group. We also looked at gene expression to look at mechanism, and what seems to be happening is we're browning white adipose tissue, and we've done this in a variety of tissues, but this is where the money is. So ME3 is our combination metabolic enhancer, our second generation, and that was the first generation. What we found is a big activation of what's called a browning program. So it converts white adipose tissue into brown, and if adipoc goes up, we should see UCP1, which is uncoupling protein. So essentially, the energy comes in, but you waste it as heat. And this is why we think this is working, and this is a Western blot at the protein level. And of course, mitochondrial biogenesis, the master regulator of mitochondrial biogenesis, PGC1 alpha goes up. The next thing that's important is that with obesity, of course, comes fatty liver. I think Pascal was here earlier. He must know about foie gras. Many of you probably know pate. So this is a wild-type animal. This is a mouse on high fat. Keep this image in your brain when we talk about the ketogenic diet. And this is the metabolic enhancer. Under the microscope, and again, this was run independently by Rick Austin, this is the normal controlled diet. This is an oil red O stain, which stains for fat. You can see the increased fat here when you give a high-fat diet, the destruction of the liver cells, and pretty much back to normal here on the metabolic enhancer, and similar to exercise. So with that fatty liver in mind, let's turn to the ketogenic diet, because there's a lot of hype about the ketogenic diet and Pompe disease. So we haven't published this yet, so some of these graphs are a little bit crude because my student went off and got into medical school and he hasn't finished his darn master's degree. Anyhow, people are interested in the ketogenic diet, so I'm gonna have to write the darn thing up. One, if you have high fat, you're decreasing carbohydrate, so that could be a form of what we call substrate reduction therapy. Less rate of appearance of glucose to the lysosome. Number two, ketones can activate autophagy. And Nina Rabin, I'm sure, is going to talk about that. So what we did is we had wild-type mice from 3 months of age, and we had Nina Rabin's mouse, which is the Pompe mouse model, at the same age, and we randomly allocated them to regular chow. We gave them myozyme. We gave them myozyme in a ketogenic diet, which was 80% fat, or we gave them a new compound, which is called 1,3-butanediol. 1,3-butanediol splits into the two main ketones, beta-hydroxybutyrate and acetoacetate, and that happens in the gut. So we wanted to use this as a non-dietary way of inducing ketosis. My hypothesis was that given that the ketogenic diet is both SRT and ketogenesis, it would be superior. Again, you're going to think I don't know what the heck I'm talking about, because again, my hypothesis didn't work. And what we found is that, yes, we got ketogenesis with the ketogenic diet, and we also got it with the 1,3-butanediol. What we found is that the ketogenic diet really didn't do very much in terms of function. So this is grip strength, and you can see that, of course, it goes down over time. Myozyme had a mild attenuation, but with the ketogenic diet, it was really no different than what we saw in the untreated animals. But with the 1,3-butanediol, we saw maintenance of their strength. And the same was true of rotorod. Essentially, this is like, you've probably seen the guys that split wood when they're in the pond and they've got the log spinning around. It's very similar, where you put the critters on a log that spins, and they did better when they were on the 1,3-butanediol. But we saw no benefit from the ketogenic diet. And then from a glycogen perspective, of course, we got clearance of glycogen with the myozyme. We saw a little bit here with the ketogenic diet. And again, very similar. So we didn't find that there was an increase in glycogen clearance. So why were they performing better? Well, one of the things that we found is that the activation of autophagy seemed to be greatest whenever we had the 1,3-butanediol. So we think that's part of it. But a word of caution, if you're on the ketogenic diet, this is what their livers look like. These are the wild-type critters, and these are actually the animals on the ketogenic diet. So in the long run, may not be the best thing for your liver. So let's turn to exercise very briefly. What might be the benefits of exercise? Well, there's general benefits that we know in the population, young people, older adults, etc. We can improve cardiovascular health, lower the risk of obesity, activate autophagy, which might be important, obviously, for Pompe disease. Perhaps we can increase capillarization to deliver more myozyme to the muscle. And we know that that happens normally. There's more capillarization, but would it improve myozyme uptake? With resistance training, of course, we can increase muscle strength, improve bone mineral density, and if you have a higher fat-free mass, you actually lower your risk of type 2 diabetes because the rate of disappearance of glucose is higher when you have higher fat-free mass. So we did a study to look at this in mice, again using Nina's lovely model. And we had the GA knockout mice versus littermate controls. And GA knockout mice, we exercised them, or they were sedentary, with and without myozyme, and we did a variety of outcome measures. Again, in the interest of time, all I'll show you is it did work. So we increased endurance time when we exercised the animals. We lowered oxidative stress, and I don't have time to get into that, but that can be deleterious to muscle. We improved mitochondrial capacity. We think we lowered oxidative stress by increasing the activation of antioxidant enzymes, and we also increased autophagy, i.e. we had more autophagic clearance in the animals. And then what's the evidence that this actually works in Pompe disease? And of course, I had to put this paper up because my esteemed colleague is the lead author on this. So this was in 44 late-onset Pompe patients after 1 year of ERT treatment. And what the hashed lines show is individuals who were doing physical activity. They were doing cycle ergometry during the infusion, and 3 of them were doing regular physiotherapy, which involved resistance and endurance exercise. And essentially what you can see here to a first approximation is that the dashed lines are always showing some signs of improvement, and in general it suggests that exercise might be beneficial, and perhaps if you're cycling during the infusion, you might increase the uptake of myozyme. We didn't confirm that in the mouse model, but clearly the improvement in function is consistent with the mouse model. So what's the first real training study? This is a Greek group in 5 late-onset Pompe patients who were receiving ERT, and they did 5 months of supervised resistance and endurance exercise. So they actually came to the clinic and they did their strength training there. Depending on the muscle you were looking at, there was a 15 to 50% improvement in strength, and importantly, 6-minute walk test reflected here improved by 45 meters. Keep in mind, I won't get into the cost of myozyme, and yes, they did sponsor some of my talks. I shouldn't be saying this, but the LOTS trial was about 31 meters, but exercise, 45, 1 for exercise. And then, of course, the lovely work by Jens van der Ploeg showing combined training, and I won't spend too much time on this because she already mentioned it, but they did training for 12 weeks, 3 times per week in adults with late-onset Pompe disease. Most were able to complete the program, and it was well tolerated, and there was an improvement in maximal work capacity on a cycle ergometer, VO2 peak, which is your max oxygen consumption, 6-minute walk test, and quantitative muscle strength test as well. And then finally, what if you put these all together? So this is an older study published by Alfred Slonim in 34 Pompe patients where he exposed them to what's called NET therapy, which is nutritional and exercise therapy. And what they looked at was the change in function before and after they started this NET therapy. And some folks were in this for as long as 10 years. So NET was nutrition, which was an increase in protein, a decrease in carbohydrate for SRT, and moderate fat. The alanine, I won't get into why that was thrown in, but probably didn't do very much. Exercise, they did treadmill exercise and arm ergometry at a moderate pace. This is where you're just starting to have a difficult time speaking, so it was fairly intense. The compliance was quite good, and what did it do? Well, what happened is this is the historical change in their function, showing that they were getting worse over a period of time, and this line here indicates when they started the NET therapy. And you can see in general that there was a stabilization or an improvement in function once they started the therapy. But those who were non-compliant, the slope of the line was very similar, so they continued to deteriorate. So again, does suggest that exercise is helpful. So what's the bottom line? And hopefully we can talk more in the final discussion. If you're going to exercise, I think there's no superiority between one or the other, and we'd recommend mixing them both up. I think it's important to start slow and listen to your body because no 2 programs fit for everyone. Be very careful of energy balance when you're exercising and eating because if you don't expend very much, and you take in still 2,000 or 3,000 calories a day, you're going to become overweight and eventually obese. But the problem is that if you cut back your energy intake to match energy expenditure, you may be deficient in a variety of vitamins and minerals. So generally, we would suggest to check and replace deficiencies. In women in particular, we see a lot of hypoferritinemia, which can cause fatigue. Vitamin B12, again, can cause neuropathy, foot drop, weakness in the distal extremities. Severe vitamin D deficiency can cause myopathy on its own. Don't pour gasoline on the fire. We would recommend a protein intake of 1.2 to 1.6 grams per kilogram per day. I don't know in terms of milligrams per pound, but you can probably figure it out as an American. But currently, the Canadian and US RDA is 0.8. So this suggests about 40 to 60% more protein than they're normally taking in. At this point, I would say ketogenic diet is still very questionable based on our animal stuff, but again, we have to see what human studies show. And again, these need to be controlled, randomized trials, not just hand-waving. So these are all the folks that were involved in the research. Thank you very much.